Assalamu alaikum. And this lecture was previously uploaded on YouTube, but unfortunately the sound recording could not be uploaded. So we are now uh, re-posting this lecture for those who probably missed the audio component of this. Right. Now this is on the pituitary disorders. This is a beautiful crow from Australia, Apollo Bay, Melbourne, captured in 2013. The case scenario is about a 22-year-old university student who presented with a 3 months history of excessive thirst. She consumes about 20 to 25 glasses of water in a day, and she has to wake up 5 to 6 times at night to pass urine as well as to drink water. She complains that she is constipated, but her appetite is normal. She has not lost any weight. Her wedding is scheduled in the next 2 months, and she is quite apprehensive about it. And talking of a differential diagnosis of a young female who has some apprehension, some anxiety, and some increased thirst, what we call as a polydipsia, and increased urine formation or urine passage, we call as polyuria. The differential diagnosis probably would start from that, considering the major symptoms of polydipsia, polyuria, nocturia, in fact, or nocturnal passage of urine, and polyuria, and maybe anxiety. Could it be all just because of anxiety and we label it as a psychogenic polydipsia? There are situations when you are anxious and you have definitely all the sympathetic activity going on, which results in tachycardia, palpitation, thirst, or feeling of being thirsty, or repeated consumption of water, and maybe repeated passage of urine as well. Sometimes this may have to be considered symptoms of diabetes mellitus, with the hyperglycemia leading on to osmotic diuresis and increased passage of urine. So polyuria, polydipsia, polyphagia has traditionally or conventionally been taught as symptoms of diabetes mellitus. And then there is another form of diabetes which is called as diabetes insipidus, and this is because of increased passage of undiluted urine because of lack of concentration of the urine by reabsorption of water by the kidneys, and this action is under the effect of antidiuretic hormone being produced from the pituitary. So that can be the third reason of passage of a more than normal or excessive amount of urine, and of course accompanied with polydipsia. Now, talking of the diabetes insipidus, it is defined as when someone passes more than 3 liters of urine in 24 hours and his urine is dilute with an osmolality of less than 300 milliosmoles per kilogram. This diabetes insipidus can be because of central causes, when we call it neurogenic or pituitary diabetes insipidus or central diabetes insipidus. This is because of lack of antidiuretic hormone secretion from the pituitary gland, and sometimes it can be not because of the pituitary but because of the receptors in the kidney where this antidiuretic or hormone or vasopressin has to act, and then the normal uh, secretion of ADH does take place, but the receptors at which it has to act in the distal convoluted tubules, they are not there, and that's why that the kidney fails to reabsorb, and this is then called as nephrogenic diabetes insipidus, and this may be resulting in the decreased ability of the mm, kidneys to concentrate the urine due to resistant to ADH action in the kidney. So in central diabetes insipidus, there is no ADH being produced. In nephrogenic diabetes insipidus, ADH is there, but it does not act on the kidney. The central the form of diabetes insipidus results from conditions which lead on to impairment of synthesis or transport or release of antidiuretic hormone. And the other name for this antidiuretic hormone is arginine vasopressin. And the central diabetes mellitus may have two forms. There may be an absolute deficiency of ADH, or sometimes this may be partial deficiency, or some ADH is being produced, and that's why the resulting signs and symptoms may vary in the totally absent ADH and a partial lack of production of ADH from the posterior pituitary. This is the diagram we did consider, and we in previous lectures as well, and we said that this posterior pituitary is a sort of a unique type of say formation. The pituitary itself is just as if that's probably the interior one is the more like an endocrine gland. It behaves like a gland, but the posterior portion is an extension of the neurosecretory cell bodies from the hypothalamus down the nerve fiber, and it is merged with or fused with, and this is actually the nerve endings which release the secretion, and this from there it enters into circulation and then it goes into cell. So strictly speaking, the posterior pituitary is an extension of a neuronal connections from the hypothalamus leading on to the receptors are primarily the vessels, and there the secretions are poured, and this when they are mm, say taken away from there through the circulation to the target organs. Now, to understand the whole of things, that this ADH, as we said, is secreted from the posterior pituitary, but primarily, as we said, it is the hypothalamus which has some neuronal impulses being, say, generated, and then this release into the posterior pituitary. They release the antidiuretic hormone, and this antidiuretic hormone, when taken up by the blood vessels from there to its target organ, which is collecting duct of the uh, kidney or nephron. And here this leads on to reabsorption of free water. So when this ADH is there, the water would be reabsorbed from the urine, but when it is not there, the water would be lost as such in the urine. Now, this reabsorption of water will then determine that what is the concentration of the circulating blood. So, when the water is lost too much, the plasma will be concentrated, and when the water is say reabsorbed in excess, then the plasma would get diluted. So, this is the plasma concentration or the osmolality of the plasma, which determines that whether the hypothalamus, if the osmolality is going high, it would lead on to say suppression of the hypothalamus to secrete antidiuretic hormone, and the loss of antidiuretic hormone lead on to loss of water. And when the concentration is low, or there's dilute plasma, then this the concentrated plasma, then there is it will be a lot of antidiuretic hormone released, and this would lead on to reabsorption of water to say reset the plasma concentration, or make it dilute. So to calculate the plasma osmolality, which is, as we said, is the main determinant of the secretion of ADH and or of reabsorption of water from the distal convoluted tubules. So since osmolality is the dependent upon number of particles or millimoles or osmoles, each particle has its uh, say osmotic value, or so the main determinant of osmolality are actually the electrolytes, and the major concentration of electrolytes is primarily the sodium, and to some extent maybe 4 to 5 millimoles in the form of potassium. Now this sodium is not alone. The sodium is always, it would have its say bound to it either a chloride or any other monovalent ion, because the ions cannot survive. They have to be in the form of molecules. So each sodium would be carrying one chloride with it. Similarly, each potassium would also be carrying with some chloride with it. So if you calculate the osmolality, the osmolality would look at as concentration of serum concentration of sodium in millimoles, added to it serum content potassium, and we multiply it by 2 so that the each accompanying chloride is accounted for. So this is if someone has serum sodium of 140 and serum potassium of 5, so 145 multiplied by 2 for all the accompanying say the chloride, this would turn out to be 290 millimoles, right? And then uh, the other determinant of osmolality or osmotic say concentration of the plasma are blood sugar and blood urea. And normally we have blood sugar in milligram, we have blood urea in milligram. We have to convert it into millimoles, and for that conversion we take the blood sugar level measured at that time when we are calculating the osmolality divided by 18, so it would convert into millimoles. Someone suppose have a blood sugar of 180, so divided by 18, it would have 10 millimoles contributed by the blood sugar level. Similarly, blood urea again is measured, normal lab measures it in milligram, and to convert it to millimoles you have to divide it by 6. Or if your lab is measuring it in millimoles, you just have to add uh, the the sum of sodium and potassium, add to it blood sugar in millimoles and blood urea in millimoles, and then you would get the total of the serum osmolality. The normal plasma osmolality is around 280 to 300 milliosmoles per liter, and you call it as hyperosmolar when the plasma osmolality it's usually it's in kilograms, milliosmoles per kilogram, and the hyperosmolality when you got is more than 320 milliosmoles per kilogram. Now, vasopressin or ADH or antidiuretic hormone, this is the one which controls the expression and cell surface targeting the apical water channel aquaporin 2 in the connecting tubules and connecting ducts of the nephron or kidney. So the site of action of antidiuretic hormone or vasopressin is the distal convoluted tubules, and there this is a certain receptors target is in the form of aquaporin 2, which is the site where this ADH or vasopressin acts and leads on to reabsorption of water. This connecting tubules and connecting ducts also are the site of amiloride sensitive sodium reabsorption via epithelial sodium channel. That's why sometimes these are the diuretic paradoxically are used for the treatment of this say and diabetes insipidus as well. They are both regulated, this aquaporin 2 and ENC are regulated by the vasopressin via V2 receptor dependent cyclic AMP production. The exogenous application of vasopressin effectively corrects the reduced aquaporin expression in the urinary concentration defect in the central type of diabetes insipidus. Diabetes insipidus results in lack of water reabsorption in the collecting ducts of the kidneys due to decreased secretion of ADH, and this would result in, of course, polyuria. And when you have a lot of water loss, this would lead on to say initiation of the thirst mechanism, and patient would also drink more water. The urine output in diabetes insipidus can range from 3 liters per day in mild or partial diabetes insipidus, as we already said, to maybe up to 15 liters per day in patient with severe disease. The central diabetes insipidus worsens or maybe first time diagnosed during pregnancy. Why? That there is a vasopressinase that is released from the plasma from the placenta, and this would lead on to increased catabolism of vasopressin. So those with the partial type of diabetes insipidus do have some vasopressin there, and they are not symptomatic because of that vasopressin. But when they during pregnancy, there is a release of vasopressinase, and that small amount of vasopressin which was there is also catabolized by the placental vasopressinase, and then this is almost a total lack of vasopressin, and this patient become symptomatic, or if they were already having partial symptom, the symptom may worsen. The etiology of diabetes insipidus of central type may be, mostly it is idiopathic, we don't know, but sometime it may result from brain trauma which would leading on to damage to the pituitary stalk. Primary or metastatic brain tumors can involve that area. Sometimes infectious diseases like sarcoidosis may be the responsible for this lack of ADH release from the pituitary. Neurosurgery, hypoxic or ischemic encephalopathy. Sometimes this diabetes may run in the families because of this, say, certain receptors being lacking. Radiation to the brain, infection, particularly this may happen transiently during meningitis or encephalitis. Cerebral trauma or edema may be resulting, and sometimes it may result from intracranial hemorrhage. There is a specific syndrome by the name of dead mode, and this is an autosomal recessive disorder with usually incomplete parentage. So sometimes it may is manifested in the families, and sometimes it is say just in the recessive form and may not manifest and may be transmissible, but it is mainly autosomal, so it can happen in both men and women. The component include that in addition to diabetes insipidus, they also have diabetes mellitus, and there is also optic atrophy and deafness. So this combination of DI or diabetes insipidus, DM or diabetes mellitus, OA or optic atrophy, and D for deafness comprises this dead mode syndrome. And this central diabetes insipidus in this defect is because of loss of ADH secreting neurons in the hypothalamus and impaired processing of the ADH precursors. The symptoms of diabetes insipidus are in the form of primarily of polyuria, and then this polyuria leads on to a lot of loss of water lack, and this hemoconcentration that happens as a result of result results in stimulation or initiation of the say thirst response, and this patient has a lot of intake of water along with. Urine output usually is in excess of 3 liters per day in adults, and it has to be, as we said, differentiated from nocturia or frequency of micturition or benign prostatic hypertrophy. But all of these conditions are not associated with increase in total urine output. It is the frequency which is increased, whereas here there is a total increase in the amount of the urine being passed. The onset of polyuria is usually abrupt. I mean, they are well till say maybe 24 hours ago, and suddenly they start complaining of very sudden loss of say this more urine in the form of polyuria, and whereas in nephrogenic diabetes insipidus or primary or secondary polydipsia, it is usually gradual, that slowly and slowly they would have gradually increasing loss of urine or polyuria worsening day by day till they become symptomatic. Most of the time the first symptom is nocturia or more passage of urine at the night, and urine mostly gets concentrated in the morning due to lack of fluid ingestion overnight. So this lack of ADH and resulting loss of concentrating ability results in nocturia. A relatively dilute urine is excreted with the urine osmolality which is less than 200 milliosmoles. You increase the water content in the urine and decrease the or dilute the urine, of course the osmolality would go down. This polyuria, as we said, would lead on to some degree of a dehydration, dry skin and constipation symptoms that may occur in central diabetes insipidus. The lab investigations, of course, showed that you would have more water lost from the circulation in the urine, so that would lead on to a little bit of hemoconcentration, and there may be mild hypernatremia. But as we said, that since it initiates the thirst mechanism, patient starts taking more water as well, So this hemoconcentration normally usually doesn't take place unless patient does not have access to water. The plasma osmolality, as we just had shown, that you calculate it by knowing the concentration of sodium and potassium, and knowing the millimolar concentration of sugar and urine, and do calculate that. And normal osmolality we said was between 280 to 300. So in it is usually in excess of 300 milliosmol per kilogram. Normal, as said, range between 280 to 295. So why this happens? The initial loss of water results in concurrent severe thirst, and which minimizes the degree of water loss. So patients usually are not dehydrated unless there is their lack of access to the water. The differentiation from the psychogenic polydipsia or other causes of polyuria would include that we usually ask the patient to have a water deprivation test, and water, when you ask in a normal individual, you ask the patient not to take water, this would lead on to result in concentrated urine being passed, because the body would kidney would try to conserve the water, right? And but in these patients which who have lack of ADH secretion, this water reabsorption would not take place, and it would take place only if you give exogenous, say, ADH from outside, and this would then lead on to, of course, reabsorption of water and the concentration of the urine. Uh, the in patients with normal thirst mechanism, this third stimulation would occur, but when central diabetes is due to central lesion, that also impairs the, say, thirst mechanism, and these patients may also have hypodipsia or adipsia, or they may not be taking water as required to compensate for the lost water in the urine. So in such cases, who either have say impaired thirst mechanism or have not access to water, in them the plasma sodium concentration can start rising as a result of hemoconcentration, and sometimes may reach up to 160 milliequivalent per liter. Normal is around 130 to 140 milliequivalent per liter. And this can also say be resulting from withholding the water in patient with these disorders, can lead on to very severe dehydration. So to say carry out the water restriction test, we restrict water so for about 4 to 18 hours. So it's better to do it overnight. Fluid restriction should be avoided, because uh, at times at night time there may be severe dehydration, volume depletion. Maybe patient might be not having access to water. So what do? We restrict the water for 40 to 18 hours, and after 4 to 18 hours, with the careful monitoring of patient's vitals and weight and all that, because this excess water loss during water restriction would lead on to dehydration, would lead on to some weight loss, and of course would lead on to some hemoconcentration as well, some electric disturbances. So you have to monitor patient's vitals, pulse, blood pressure, urine output, weight before and after the completion of test, and of course you have to measure their serum electrolytes as well, and calculate their osmolality every 2 hours by the formula we already have say elaborated. The test should be continued till either your urine osmolality reaches above 600 milliosmol, indicating that the kidney, both ADH and its effect on the kidney are intact, because only then water restriction will result in increased urine osmolality if ADH action is there, and that would result in reabsorption of most of the water, say, filtered through the nephrons. or that you check the urine osmolality is stable in 2 or 3 successive measurements, or the plasma osmolality, if it exceeds 295, that again would suggest that you have lost much on the urine, and these plasma hemoconcentration is taking place. At that stage, you give exogenous ADH, which is either in the form of a nasal inhalation or maybe in the form of an injection given subcutaneously, and this would should result in subsequently increase in urine osmolality and decrease in the plasma osmolality over the next 3 to 4 hours. The in patients who have complete central diabetes insipidus, the plasma osmolality is increased, but urine osmolality remains below 290 milliosmol and does not increase. And when urine osmolality will increase by approximately 200 milliosmol in response to exogenous ADH. Whereas in a patient with partial, say, central diabetes insipidus, the urine osmolality will increase to somewhat as a result of water deprivation, but still it would be below normal people. Normal had a more than 600 milliosmol. And when you give them, say, ADH, this would lead on to the osmolality being increased in the urine and the plasma osmolality going down. So, how do we interpret this water restriction test? In normal subjects or with patient who have primary polydipsia only or psychogenic polydipsia, urine osmolality would be greater than plasma osmolality after water restriction. So you restrict their water, their urine should get concentrated, and their urine osmolality would be much more than it would be normal. Urine osmolality would increase minimally with the addition of 10 or maybe less than 10% if you give exogenous, which means that their internal ADH secreting mechanism is intact and its action is intact. Whereas a patient with central diabetes insipidus, urine osmolality remains less than plasmolality even after deprivation. So you restrict the water, you expect that urine should get concentrated as a result of water being reabsorbed, but since there is no ADH to do this, the urine osmolality would remain low, and when you give ADH, the urine osmolality would increase by 100% in complete central diabetes insipidus and about 50% in partial central diabetes insipidus. Whereas in nephrogenic diabetes insipidus, since the nephrons lack receptors for ADH, urine osmolality would remain less than plasma osmolality during water deprivation, and when you give up ADH, even then urine osmolality would either not increase at all or maybe increased by less than 50%. Treatment of this condition is that you replace fluid, which is the most important thing, that you don't let them dehydrate. Encourage their oral water intake. Sometime in severe dehydration, you would require IV fluids such as 5% dextrose if the patient is unable to take fluids by mouth. Why 5% dextrose? Because the glucose would be absorbed and all you need is replace the free water, rather than by giving saline you would be adding more saline to the plasma, and they are already having hemoconcentration or have some hypernatremia, so this hypernatremia would worsen. The treatment, apart from the general management of having the free access to water, the other is that you give exogenous desmopressin or vasopressin or ADH. This is available in both subcutaneous form, it is available, can be given in intravenous form. It is also available as intranasal spray, and oral preparations are also there, and usually the administration is 2 to 3 times. Most convenient form is in the form of a nasal spray. This is safe even during pregnancy. As we said, that some of the patients may have worsening of their diabetes insipidus during pregnancy because of this. vasopressin is being released from placenta, so it can safely be given during pregnancy. You need to monitor for their fluid retention and hyponatremia during initial therapy. You have to keep a record of how much water they take and frequency of and volume urination, and inquire about their thirst as well. We need to monitor their serum sodium and 24-hour urinary volumes and specific gravity, and they should be followed up every 6 to 12 months for the routine checkups. The other drugs which can be helpful, they can be chlorpropamide, carbamazepine, clofeprate, prostaglandin inhibitor, and thiazide diuretics. A word about thiazide diuretics, that how does this uh, on one hand, these are diuretics, which means that would lead on to more loss of water. And the patient are already having diabetes insipidus and they're losing more water. So how would they help? Now this is interesting. The thiazide diuretics, what do? They inhibit the sodium chloride uh, co-transporter in the renal distal convoluted tubules. Like, so if you block this sodium chloride co-transporter distal convoluted, what would that result? This is since this is impermeable and considered part of the diluting segments, the antidiuretic action of thiazide is secondary to the increased renal sodium excretion. So what the blockade of sodium chloride co-transporter in the distal tubule would lead on to more sodium being lost in the distal convoluted tubules. Now this renal sodium loss causes a little bit of extracellular volume concentration, and this leads to decreased GFR. Now this GFR, when it is reduced, would lead on to increased proximal tubular sodium uh, reabsorption, water reabsorption. Hence, the less water and solutes are delivered to the distal tubule and collected ducts and are lesser lost in the urine. So, by say blocking the sodium chloride co-transport in the distal tubules, you create a sense of some degree of say dehydration, and resultant proximal reabsorption of water is and sodium is enhanced through. So this is how this antidiuretic effect of the this thiazide diuretic is mediated. We'll talking about another case scenario, and here this is a 56-year-old male who presented in emergency room with altered state of consciousness for the past 2 days. He has been chronic smoker and undergoing investigation for hemoptysis and weight loss. His chest X-ray showed a right apical homogeneous shadow. His ESR was 85. His serum sodium, look at the serum sodium, was 118 and potassium was 3.2. So sodium is, the normal serum sodium concentration is 125 to 135 milliequivalent. So 118 is quite low, or we may call it hyponatremia, with the near normal or slightly low potassium levels. His BUN and creatinine were normal, and so was his thyroid stimulating hormone. So what's the most likely diagnosis of hyponatremia in this gentleman who is 66 and chronic smoker, has a weight loss? There is a right apical shadow, ESR is 85. So how do you link these together? And this probably is a case of maybe primarily a bronchogenic carcinoma or any other lung pathology, and there is an exogenous production of ADH from those say tumors, and this exogenous lead on to a lot of say water being reabsorbed, leading on to hemodilution. This situation is called as syndrome of inappropriate ADH. Like, the appropriate ADH, what is it? Appropriate ADH, when ADH would be say secreted from the pituitary when there is a lot of hemoconcentration taking place, when there is a solute is going up and there is a hemoconcentration. So in response to increased plasma osmolality, there would be release of ADH, and this ADH would lead on to an increase in urinary osmolality, but because water being reabsorbed and dilute urine being passed. But what is happening in this patient who have exogenous ADH being produced, that despite normal plasma osmolality, despite normal or near normal, even low plasma osmolality, there is a release of ADH, and this ADH release results in reabsorption of water and being urine osmolality being increased and plasma getting diluted. So this is an inappropriate ADH release and results in hyponatremia. So there is hyponatremia. Urine osmolality is usually more than serum osmolality. Why? Because serum is getting diluted because of the ADH being secreted, and urine is getting concentrated because the ADH leads on to water being reabsorbed and urine getting concentrated. So whenever you have a situation where urine osmolality is more than the serum osmolality, this is would be considered as inappropriate ADH response or ADH release. The other determinant of osmolality of are usually BUN, creatinine, sometimes TSH also leads on to hemodilution and hyperglycemia. So they are usually all normal. Why it happens? This can result, as in the example we narrated, from bronchogenic carcinoma or neoplasm. Other pulmonary disorders like pneumonias or emphysema, cystic fibrosis, status epilepticus, and renal failure may also lead on to release of more ADH. Particularly, this is seen in Legionella pneumonias. Some intracranial pathologies like trauma, neoplasm, infections like meningitis, encephalitis, brain abscess can result in SIADH. This is usually maybe seen as in patients who has undergone surgery, and during surgical stress there is again a release of more ADH, and patients on ventilators or say under the effect of anesthetic agents may also have an inappropriate release of ADH resulting in hyponatremia. Some drugs like chlorpheniramide, thiazide diuretics, chemotherapeutic agents like carbamazepine, phenothiazines, monoamine oxidase inhibitors, tricyclic antidepressants, narcotics, nicotine, clofebrate, haloperidol, and so when someone has SIADH, you have to consider maybe a pulmonary pathology, maybe say a exogenous release of ADH from lung, say malignancies, and maybe you have to consider certain drugs as a culprit as well. Sometime it may also be seen in patient with the intermittent porphyria, myxedema, psychosis, and sometime in patient with ACTH deficiency or hypopituitarism. The treatment is simple, that all you need to do is restrict their fluid, and this restriction would lead on to hemo concentration and would, right? And sometime when it is say the serum sodium concentration falls below 120 milliequivalent, you might have to give hypertonic saline intravenously. The normal saline or isotonic saline has a concentration of 0.9% say sodium, whereas the hypertonic saline would have either usually 1.8% or sometime maybe up to 3% of sodium. You have to focus on the underlying problem which is causing this inappropriate ADH release, which may be medicine like antidepressant, psychogenic, antipsychotic drugs, or it may be the stress of a surgery, or it may be a pulmonary disease, or maybe sometime underlying malignancy. Thank you very much for your say patient listening, and this I hope that this time the voice is okay and you will be able to understand, or you will have to note what explanations for each say presentation was to be done. Thank you.